on that.
Yeah, that's okay. I will introduce Dr. Murli. Murli is my one of the favorite SR at Nimhan, so I want to introduce him.
We are recording now. So, a very warm welcome, good evening to the 207th edition of Thursday Musing. Uh, Today's topic is treatment of bipolar depression, current standards, and future directions. So, uh, first we'll introduce the speaker, then there will be deliberation by the speaker. Everyone will be on the mute mode. The questions are invited in the chat box. So please post your questions in the chat box. We'll take it up to the presenter. And next is I would like to hand over the session to Tofan Pati sir to introduce the chairpersons. Next slide, please. And over to the chairman of this program, Professor Dr. Tofan Pati sir. Sir, over to you.
Thank you, Dr. Ali. And I shall have to introduce formally our moderators, Dr. Amrit Patadasi, Secretary IPS, Dr. Alim Siddiqui, Treasurer IPS, and Dr. Vishal Chhabra from Delhi, who is a vibrant moderator for the last few days. And welcome all three of you. I have the pleasure to introduce Dr. Gulbahar Singh Sidhu, consulting psychiatrist based at Jalandhar in Punjab, and Honorary Treasurer IPS North Zone, Vice President cum President-elect Punjab and Chandigarh branch of IPS, Honorary Treasurer Punjab and Chandigarh branch of IAPP, Editor Beyond Borders, Official Magazine of Short Psychiatric Medicine. Welcome, Dr. Sidhu. Next, please. Dr. Om Prakash, affiliation, Professor of Psychiatry and Deputy Medical Superintendent, Nodal Officer, Telemanas Regional Coordinating Center, 6 states, Ministry of Health and Family Welfare, Unit Head Geriatric Psychiatry Unit, country's 3rd unit. Notable achievements, senior faculty for last 15 years at IBHAS, Delhi, past demands and PGI-MER, recipient of the 2 ICMR awards and numerous other recognitions. Other professional affiliations, Direct Council member, leadership roles within IPS and related committees, research updates, 250 plus publications in various national and international journals, editorial board of 13 journals and reviewer in 30, 7 research projects, 30 PG dissertations. Important professional assignments, Chief Quality Coordinator, IVAS, Member Technical Expert Working Group and Government of India. Awards in this Indian Council of Medical Research, Professor Surinder Mohan Marwa Award of 2010 for Geriatrics, Tilak Venkabra Award 2007 for Psychological Medicine, Sarkian Psychiatrist Award 2008 for, and 2 awards from IPS, contributions in the field of psychiatry and geriatrics. Welcome, Dr. Om Prakash. Welcome, Dr. Sidhu. From here on, the meeting is yours. Chairperson will take over. And someone will introduce the
So thank you for introduction. I want to introduce my colleague. I think something I heard in Nimhans. I love Nimhans because I served almost 5 years there. And Dr. Muralidharan is the one of the brilliant chair that I met, and almost we are long associated till now. Till now, because we have Nimhans and Nivas, and a lot of things go to president of Nimhans this now long time, and he was a psychiatry. He finished his MBBS from Bangalore Medical College, and then PG from Nimhans, and he finished MBA from Madurai Kamra University. His affiliations are his visiting professorship, Mood Disorder Center of Excellence, Vancouver, Canada. He's Vice President of Neuromodulation Society of India, Co-Chairperson IPS Neuromodulation Special Section. He's IPS Life Fellow, Karnataka's IPS Chapter Life Fellow, and ISBD, that Bipolar Disorder India Life Fellow. He mentioned, slide mentioned area of research for mood disorders, but I know Murugan for because he is the pioneer of making center of addiction medicine at Nimhans. So one of the persons who helped Dr. Pratyam Murthy and Dr. A. Benegal in actually establishing this very important center of addiction medicine. Herein, this is specialization in mood disorders, non-invasive brain stimulation psychiatry. He got a lot of awards and distinctions. Professor Overall Distinguished Young Teacher Award, Samuel Wilson Award. This is the peer-reviewed publications in test journals, and a lot of collaborations with NIMH, UBC, Deakin Institute, Board Institute, and we received DBT and district grants for bipolar disorders, distribution psychiatrists, and he's actually did a country in IJP in the subsidiary section mood disorders. So welcome, Dr. Murli, and really I am very fond of you since when I joined. I remember when I joined NIMAS as a faculty, the way you expression those things and the way you worked hard, really, you're a great asset for NIMAS. Over to Dr. Sidhu.
Thank you, sir.
Good evening, everyone, and a very warm welcome to Dr. Muralidharan Keswan. We are all eager to hear from you, sir. It's a very important topic, I must say, and for a clinician like me, I think it is even more important because this bipolar depression is very difficult to treat. And most of the time, what I have seen is that patients come to us after visiting physicians, and their instinct is the moment they see a depressed patient, they'll prescribe an antidepressant without bothering that it patient is a bipolar case. So I think I don't want to take too long, and we are all eager, sir. Please, Dr. Muralidharan, over to you.
Thank you, sir. Very good evening to all. And thank you, Om Prakash, sir, for that very kind and generous introduction, and Gulbahar Sidhu, sir, for introducing the topic. At the outset, uh, okay. So I have no conflict of interest to disclose, and let me place on record my appreciation to the Thursday Musings team, Professor Tofan Pati sir, Dr. Amrit Patajoshi, Dr. Aleen, and Dr. Vishal, for giving me the honor of being here on the 207th edition of Thursday Musing, and congratulations on the Guinness record that you've set. And I also like to take this opportunity to thank my colleagues from the Department of Psychiatry and all my collaborators in this particular topic. So this is the outline of my presentation. I hope I'm audible and clear. All right,
Yes,
thank
sir,
you.
you are.
Thank you. So this is the outline of the presentation. So I'll initially talk about some of the challenges in diagnosis and treatment of bipolar 1 depression. Then what is the evidence for treatment and what do the guidelines say? A couple of slides each on bipolar 2 depression and treatment-resistant bipolar depression. Then we'll talk a little bit about advances and future direction, including the topic that Dr. Sidhu alluded to, the role of antidepressants in treating bipolar depression, current pharmacotherapy, novel targets treatment, a little bit about non-invasive brain stimulation. Right. So, what are the challenges in the diagnosis and treatment of bipolar depression? Now, it's a significant treatment challenge, and like Sir mentioned, a significant unmet need when it comes to the treatment of bipolar depression. While we do say that mania is more common in India and Asia compared to the Western countries, patients spend 3 times more amount of time in depression than in mania. The depressive episodes tend to run longer. Most of the patients are euthymic for less than 50% of the time. A lot of high suicidal risk, disproportionate to the general population in patients with bipolar depression. And despite all this, patients tend to be more non-adherent in bipolar disorder in general and bipolar depression in particular, which forms a major treatment challenge. So, what are the phases of treatment? Just for a quick recap. So, we have the acute phase, the continuation phase, and the maintenance phase. So, this particular talk, I'll focus a little bit more on the acute phase of treatment of bipolar depression. So, this case vignette, I'll just read out briefly. We can come back to this a little later. So, a 32-year-old lady with 2 children presents with 4 months history of acute onset of pervasive low mood, crying spells, loss of interest in all activities, feeling tired most of the time, frequent awakenings at night, poor quality of sleep, withdrawn behavior, reduced appetite, death wishes, hearing voices that say you are evil, you will die, feelings of pessimism, occasional suicidal thoughts but no attempts. There is past history of one manic episode lasting for about 2 months. The last episode was 2 years ago. Patient received treatment with quetiapine 600 milligrams per day for 16 weeks. and lithium 900 milligram per day for 12 weeks at 0.8 milliequivalents per liter. Stopped 1 year ago. So this is the case vignette. I'll come back to this a little later in my presentation. So here we're looking at a patient who has acute bipolar depression. Now, bipolar depression, what would be a clinical challenge? Now, this, I think, would be one of the major clinical challenge for clinicians, especially when a patient presents with a depressive episode very early in the course of illness. The diagnosis is easier when the patient has already had a manic episode. So, what are the clinical features that would help us distinguish bipolar depression from unipolar depression? So, the features that could favor bipolar depression include early onset of depression, less than 25 years of age, multiple prior episodes, positive family history of bipolar disorder, reverse vegetative signs, signs of atypical depression, presence of psychomotor retardation, presence of psychotic features of pathological guilt, and of course, postpartum onset of symptoms, presence of comorbid substance use and anxiety disorder. These are some characteristics that could help the clinician decide that this patient is possibly has bipolar depression and may go on to develop bipolar disorder over course of time. So the kind of contradicting features are seen in patients with unipolar depression. So this is one way of clinically distinguishing them. The second clinical challenge for clinicians that I would say is the suicidal risk. The standardized mortality rate for bipolar disorder is 20, which is 20 times greater than the general population. Now, if we were to do a risk stratification for patients for risk of suicide and mood disorders, we'd find that bipolar 1 and 2 have the greatest risk, followed by those patients with severe depression who are currently hospitalized, followed by moderate depression. So, vis-a-vis major depression, the suicidal risk is that much higher in bipolar disorder, and the risk is comparable in bipolar 1 and 2. So, when is the risk of suicide greater? In individuals following hospitalization, the first 2 to 3 years of illness, when there are mixed features that are seen as a part of the bipolar depressive episode, patients with comorbid substance dependence, and understandably those with prior suicidal attempts. In a study that we had done here at NIMHANS on 180 patients with bipolar disorder, almost 9% of the sample had current suicidal ideation, which is quite high. So, bipolar depression, suicidal attempts are quite common. These some of the risk factors. I'm sure most of you are aware of it. So, I'm just going to run through this slide. So, there are various determinants that could contribute towards the risk for suicide and bipolar disorder. For management of bipolar depression. So, what are the challenges in treatment? So, one of the challenges is that a lot of times bipolar depression gets misdiagnosed, especially if the manic episode is not very severe or has been missed. Unipolar depression or recurrent depressive disorder is a common misdiagnosis. The other challenge is that inter-episode depressive symptoms can be very, very prominent and disabling. The number of treatment options for bipolar depression are limited. And once you start treating the patient who don't respond, the therapeutic options get exhausted very rapidly. So this is what the CADMAT guidelines talk about in terms of acute bipolar depression treatment. So the approved first-line treatments as per CADMAT include betiapine, lorazepam, either in combination with lithium or valproate and as monotherapy. Of course, the combination therapy works better than monotherapy. Lithium, lamotrigine, or adjunctive lamotrigine have been put down as first-line treatment. Now, if you look at all the FDA-approved treatments for bipolar depression, you can actually count them on the fingers of one hand. So, what are the drugs that are available as per FDA approval? One is olanzapine and fluoxetine, which was approved in the year 2003, quetiapine in the year 2008, lorazepam 2013, cariprazine 2019, and lumateperone about 2 years back. So, as you can see, the options are very less. The number of drugs that are approved for the treatment of acute bipolar depression, the drug development has taken a fair bit of time. And so the options that we have are quite limited. So these are mostly the second generation antipsychotics that we're talking about here. So we recently had the opportunity to review the evidence for pharmacological treatment of bipolar disorder in this IPS South Zone update on bipolar disorders. And this is what we found in terms of what the treatment guidelines say. So here we've tried to compare 4 different treatment guidelines, the RANSOM guidelines, CANMAT guidelines, and we have the clinical practice guidelines of IPS and the British Association of Psychopharmacology guidelines. Now, how are these guidelines different? So if you look at what is the first line treatment, CANMAT guidelines, IPS CPG, and the BAP guidelines were put down quetiapine, lurasidone, either as monotherapy or in combination, lithium, lamotrigine, lurasidone, again, monotherapy. But if you look at what are the second choice treatments, Lancet guidelines puts down quetiapine as second choice. Likewise, lurasidone and cariprazine. Whereas the first choice, according to the Lancet guidelines, are lithium, valproate, and lamotrigine. So that itself is a significant clinical challenge. So what does the clinician follow? Now, if you look at the IPS CPG guidelines, which is the third column here, the first line treatment is either monotherapy or combination with lithium, lamotrigine, quetiapine, olanzapine, fluoxetine combination, valproate plus lithium, which is very unique here, valproate plus antidepressant. Now, one of the few guidelines which talks about using antidepressant in the first line treatment. Likewise, the British Association of Psychopharmacology guidelines also talks about a combination of antidepressant plus antipsychotic or mood stabilizing drug, which is most likely an anticonvulsant, as a first line treatment for acute bipolar depression. So, as you can see, there is some degree of overlap between the guidelines, but the guidelines also seem to differ on what could be first line and what could be second line treatments for acute bipolar depression. And when you go further down the chart, you will see that there's a significantly more variation between the four guidelines. So that's one of the things that we put down as a clinical challenge where, which guideline does one follow? Why, how can we look at, commonalities between guidelines which can help guide clinical practice? So what do Indian psychiatrists do? So what do we do rather, I should say? So this is something that was published a few years back. 500 psychiatrists from the IPS directory were polled and they were asked for their opinion on what kind of prescriptions are provided in patients with bipolar disorder. And when it came to acute bipolar depression, as you can see, the top 6 choices are kind of overlapping with each other. The most common choice of an Indian psychiatrist, as per this survey, is a mood stabilizing agent plus an SSRI. So that is what we are looking at in clinical practice, that an antidepressant is used far more commonly than what guidelines recommend or what evidence says. So here you have a situation where the clinical practice is far removed from what guidelines say, but then this is what has been used. And then if you look at second line options, you will still find that the mood stabilizing drug plus SSRI also features very prominently here. In addition, we have some very interesting combinations that are there in terms of what our fellow professionals are using based on their own clinical experience. You have valproate plus lamotrigine, which figures fairly prominently. You also have some who have used SSRI or TCA alone, which is quite unique. We also have a small subset of people who are using a combination of mood stabilizing drug and tricyclic antidepressant. So as you can see, what the guidelines say, what we do seem to be there seems to be some degree of mismatch, even though there is a lot of overlap also between what guidelines recommend and what is being done. The data currently may be slightly different, but then I have no access to the data. So, what is the treatment algorithm for bipolar depression? So, this is what we should do in terms of a flowchart. So, look at the general principles of assessment, do a life charting for bipolar disorder, look at predominant polarity, look at the number of episodes, look at interepisodic function, look at inter-episode mood symptoms, and then also do a suicidal risk assessment for the current episode. The current episode, understandably, is bipolar depression here. So we will initiate and optimize with the following treatments: quetiapine, lurasidone, lithium, or lamotrigine. Step 2 would be to add on or switch to alternate treatments, again from the first line treatments. Step 3 would be to add on drugs like valproate, SSRIs, or adjunct to bupropion. And then step 4 would be to look at other treatments like olanzapine, risperidone, aripiprazole, lisinopril, carbamazepine, etc. Now, one of the things that this particular guideline, CanMed guideline, has done is to push olanzapine down the order in terms of its preferred line of treatment. So it went from first line to second line for the simple reason that the long-term use with olanzapine can cause significant metabolic side effects, which in itself could be quite distressing to the patient. So these are again some of the drugs that have been tried in acute bipolar depression. So if you just look at the summary on the right side of your screen, about anticonvulsants, antidepressants, and antipsychotics have been the main drugs that have been tried. There are various trials for each class of drugs. And in lithium, there is one particular trial. And this is what is available for us to use in the acute treatment of bipolar depression. So if you actually look at what this network meta-analysis told us in terms of efficacy, we find that valproate, olanzapine fluoxetine, olanzapine quetiapine, cariprazine, and lamotrigine appear to be effective compared to placebo in treating bipolar depression symptoms. What was not found to be as effective were escitalopram, phenelzine, oclobamide, carbamazepine, sertraline, lithium, paroxetine, aripiprazole, gabapentin. So I'm just reading out from the results section. So you have some drugs which have been shown to work well in this network meta-analysis vis-a-vis placebo, whereas some of the other drugs which we commonly use were not found to be as efficacious in this network meta-analysis. So in terms of drugs or medications that can also reduce suicidal risk in bipolar disorder patients, of all the categories of drugs that we have, the ones that have shown some degree of efficacy against suicidal ideation would include lithium, which we're all well aware of. There's a consistent decrease of risk of suicidal attempts as well as ideation, whereas ketamine has been shown to reduce suicidal ideation. Its effects on suicidal behavior are not really well described. The other somatic treatments, we all know ECT is probably the most effective treatment in the history of medicine, let alone psychiatry. And of course, we now have deep brain stimulation and TMS and other brain stimulation techniques that are being used quite extensively in reducing the suicidal risk in bipolar disorder patients. So I'm going to talk briefly about each of these drugs, their relevance to bipolar depression. Lithium, when you look at lithium, of course, we know how effective it is in treatment of acute mania and in the prophylaxis of bipolar disorder. Whereas when it comes to bipolar depression, the evidence is probably not as clear. Probably we don't have as many studies as we would like. And the meta-analysis did show that lithium was no more effective than placebo and less effective than venlafaxine, the emboldened study. Whereas guidelines are divided on the role of lithium. While CanMed guidelines recommends lithium as a first-line treatment, we did see that some of the other guidelines are looking at it as a second-line treatment. So it still comes down to what the clinician thinks in terms of the efficacy of lithium in treating acute bipolar depression. In terms of quetiapine, it's a lot more comforting, I would say. We have about 11 trials of quetiapine in acute bipolar depression. The important thing to note here is that all the trials have used doses of either 300 milligram per day or 600 milligram per day, except in the pediatric study, the very first one, where a dose of 150 to 300 milligram per day was used. So that's one good thing. So we know that anything between 300 and 600 mg can work for acute bipolar depression. The study duration for most of the studies have been at least 8 weeks. So it's fairly good trials, and we found that both in response and remission, the quetiapine is significantly superior to placebo in treating acute bipolar depression. This is a rather old meta-analysis on valproate in acute bipolar depression, where valproate was shown to have a slightly more efficacy than placebo. If you look at the test for overall effect, it was quite modest, 2.06. And if you look at lamotrigine, I mean, all of us are aware of this particular meta-analysis, which actually brought lamotrigine back into business in bipolar depression. While it was initially written off as a drug that did not show much improvement in acute bipolar depression, when this meta-analysis was done, it did show that in bipolar depression, lamotrigine seems to work well when it is prescribed for a longer period of time. And one of the challenges with lamotrigine is the slow dose titration that is recommended, which makes it difficult for us to actually study how effectively lamotrigine can treat acute bipolar depression. And of course, we have lorazepam, which has come out in the last few years. So this is a network meta-analysis that has compared lorazepam to other medications for acute bipolar depression. And when you look at the remission rates with lorazepam, it is far superior to placebo, aripiprazole, and ziprasidone, which is on the right side of the screen. But it's comparable efficacy to quetiapine and slightly better than olanzapine. So lorazepam at doses of 80 to 160 milligram per day has been found to be quite efficacious in treating acute bipolar depression. The problem with using lorazepam is that its efficacy in mania is not well established. The published study did show that the p-value is about 0.056, slightly more than what would be a significant p-value, but of course it's not recommended for use in mania, so that's a challenge. If you're using this, it's only to treat bipolar depression. Cariprazine, the more recent edition, of course, at dose of 1.5 to 3 milligrams per day, it has been found to be a little higher at 3 to 12 milligrams per day. And the efficacy in waning symptoms is far, far superior to its efficacy in acute bipolar depression. This is a recent study that we have submitted and got accepted to Journal of Psychiatric Spectrum, where we looked at cariprazine as monotherapy for acute bipolar depression. And this is what we found, that in terms of both response and remission rates as monotherapy versus placebo, the cariprazine arm was performed significantly better in treating acute bipolar depression than the placebo. And of course, a slide on clozapine, mainly for its role in treatment-resistant bipolar disorder. So, this clozapine has been shown to be quite efficacious in treating various aspects of treatment-resistant bipolar disorder, including bipolar depression, rapid cycling, psychotic symptoms, and suicidal. Right? So, what are the clinical factors that drive treatment choices? Now, more often than not, these are some of the things that the clinicians will keep in mind while deciding on the treatment option. So, if you're looking at what is the rapidity with which the response is required, or if a patient is suicidal, invariably we're going to reach out to ECT as a first choice of treatment. Apart from that, if you look at it in terms of the rapidity of response, ECT is the most rapid, followed by quetiapine, followed by lorazepam, followed by cariprazine, and then olanzapine fluoxetine combination. So rapidity of response, quetiapine is definitely a good choice. A lot of patients show improvement within the first 1 week of starting quetiapine, within 3 to 4 days actually, and lorazepam within the first 1 week of starting treatment. You would expect to find some improvement in bipolar depression. You're also looking at prior treatment. So if there has been past good response to particular medications, it is often prudent clinically to go back to the same medication. We also keep in mind while choosing the medication, what is the prophylactic efficacy of the same medication? For example, if I were to choose quetiapine, does it treat manic episodes? Does it prevent manic episodes? Does it treat bipolar depression? Does it prevent bipolar depression? So a choice is also based on its efficacy in the current episode as well as its prophylactic efficacy. If there are associated features, which we see more often than not, there are some drugs which possibly work better. For example, patients with anxiety symptoms have been shown to respond better to quetiapine and to olanzapine fluoxetine combination than the other drugs. Asenapine is another drug that has been shown to have improvement in anxiety symptoms associated with bipolar depression. And if there is mixed features, it would be important for us to avoid antidepressants, particularly tricyclic antidepressants, which could trigger off a switch. Some of the other factors include presence of atypical depression, wherein they may benefit more from an SNRI rather than SSRI, and the presence of psychotic symptoms, which would indicate an antipsychotic definitely. So these are some of the clinical factors that could guide treatment choices for clinicians. So bipolar 2 depression, just a couple of slides. So this is a chapter that we had written for a book in 2016 with treatment of bipolar disorder. I had the opportunity to write this with Dr. Lakshmi Atham. So what is the approach to diagnosis? Again, the most common challenge with bipolar 2 depression is to make an accurate diagnosis. Major depression or recurrent depressive disorder is the most common misdiagnosis with bipolar 2 disorder, for the simple reason that hypomania is not very easily diagnosed and is often missed both by the family members and by the clinician. So when we are looking at individuals who look like recurrent depressive disorder, one of the things that we need to see is to look for indicators of bipolarity. That includes reverse vegetative symptoms, younger age at onset of depression, antidepressant related affective switches, family history of bipolar disorder, and comorbid substance dependence or anxiety. Then systematically probe for hypomanic symptoms. One of the most common things that we do is to use the mood disorders questionnaire, which is an 11-item questionnaire that helps us understand if the patient could have had past hypomanic episodes. Then consider all possible differential diagnoses, including bipolar 1 disorder. It's not often that mania, which is very severe, is usually reported, but some of the milder forms of mania may go unnoticed or undetected. So bipolar 1 disorder, borderline personality disorder, attention deficit hyperactivity disorder, particularly in the adolescent onset illness, and substance induced bipolar disorder. These are some of the common differential diagnoses, and confirm the diagnosis with close monitoring over a period of time. So, what are the drugs that are available to treat bipolar 2 depression? Quetiapine remains the only first line drug at doses of 200 to 400 milligram per day, which is slightly lower than what is used in bipolar 1 depression. Most of the other drugs that are available include lithium, lamotrigine, bupropion adjunctive, ECT, sertraline, and venlafaxine. And of course, bipolar 2 depression, there have been a lot of studies which have looked at antidepressant monotherapy alone in treating acute bipolar depression, bipolar 2 depression. A few slides on treatment-resistant bipolar depression. Again, the same case vignette. I only added this particular line. Patient has received treatment with quetiapine 600 milligram per day for 16 weeks, lithium 900 milligram per day for 12 weeks at 0.8 milliequivalents per liter, and is currently also receiving lamotrigine 200 milligram per day for 4 weeks. The reason I put this is to highlight the importance of clinicians to decide whether the patient has received an adequate dose of the medication for an adequate duration and at the therapeutic levels that have been recommended. Only then we could look at making a diagnosis of treatment resistance. So, treatment-resistant bipolar depression has been difficult to define. There have been some attempts at developing consensus definitions, including this one that came out in 2018 based on the British Association of Psychopharmacology guidelines. So, what is the criteria according to this particular article? A patient is diagnosed with bipolar 1 or 2 disorder who currently fulfill the criteria for a moderate or a severe major depressive episode and who fail to reach sustained remission for at least 8 weeks or did not tolerate 2 trials of adequate therapeutic doses during 8 weeks with at least 2 treatments from box A, monotherapy treatments. And they've listed olanzapine, quetiapine, lurasidone, and lamotrigine, and at least 1 treatment monotherapy in box A and 1 treatment in box combination with different treatment in box B. So this is something again, it's very difficult to define treatment resistance in bipolar disorder, unlike schizophrenia, which is rather more straightforward. So what are the treatment options for resistant acute bipolar depression? CIP guidelines have reviewed about 149 studies, including 69 RCTs, 32 open label studies and all that. And, we've already exhausted whatever options are there as far as the second line treatments. So basically every other drug that has been tried has come to the party here in treating acute bipolar depression, including light therapy and modafinil, pramipexole, lithium plus lamotrigine. So most of the other drugs that have been tried can be tried by the clinician in various combinations once the first and second line treatments for acute bipolar depression have been exhausted. So, excuse me. So I'll go to this important question that plagues us and something that we've seen is quite common in terms of clinical practice in India, antidepressants and bipolar depression. So I'd like to answer it like this. Do antidepressants have a role in treating bipolar depression? Which antidepressants are used? And how long do you continue antidepressants? So again, I'm going to refer again to the same study from IPS, 500 psychiatrists randomly selected, 95% of them prescribed an antidepressant with mood stabilizer for bipolar depression, not necessarily as first choice drug, but as any choice. And SSRIs are used by 88% of our psychiatrists, but not really bupropion, which is something that we are taught can be used in bipolar depression with a limited risk of switch. ECT is often preferred as the first choice drug, particularly in patients who are suicide. So this is some of the findings that came out, like I presented this slide earlier. So what we're seeing in clinical practice is a fairly common use of antidepressants as first-line treatment for acute bipolar depression, but very encouragingly in combination with a mood stabilizing agent. So when we're looking at this, I think the crucial thing is to ensure that the mood stabilizing agent is always at an adequate dose or at a recommended dose. So there's another meta-analysis which spoke about adjunctive antidepressants for acute treatment of bipolar depression. It was published in the year 2022. So they've reviewed most of the studies that are available. If you're looking at what are the antidepressants that have been tried, these are the usual suspects, the SSRIs, sertraline, paroxetine is there, and then you will find citalopram and fluoxetine. You also have some drugs like agomelatine, and then you have bupropion, which features in 4 or 5 different studies. So there are many antidepressants that have been tried. But what exactly has been their benefit in acute bipolar? Again, let me again highlight the same fact that all these studies have used antidepressants as adjunct to a mood stabilizing medication, more often than not an anti-epileptic or an antipsychotic, which has been used, which has been shown to have mood stabilizing property. Most common one used here has been quetiapine, olanzapine, or long-acting risperidone. So what did the study find? So in terms of response rates, they were the combination of a mood stabilizer plus antidepressant was not significantly more efficacious than mood stabilizer alone. So that is one particular finding. And then in terms of remission rate, again, the finding are very similar. There was a trend to statistical significance, but then it was not superior. So while our clinical practice does reflect that we use antidepressants fairly commonly, this particular meta-analysis seems to show that addition of an antidepressant does not seem to have any added benefit in terms of response and remission in bipolar depression as compared to a mood stabilizer alone. So this is some chart that can help guide clinical practice. So if you're having a patient on a spectrum of depression, where bipolar depression is at one end and unipolar depression is at the other end, and bipolar 2 depression is in the middle, the bar there represents what is the role of a mood stabilizer or a second generation antipsychotic. So you're looking at bipolar 1 depression, mood stabilizer or SGAs have a greater role. If necessary, add second generation antidepressants to that particular combination. As you go down the spectrum for bipolar 2, the role of mood stabilizers and SGS kind of starts coming down, and there is more of a role for second generation antidepressants. Whereas as you go towards unipolar depression, the role of antidepressants is that much higher, and the role of mood stabilizers are a lot less than what we would find with bipolar 1 depression. So what about mood switches? Is it something that we need to be concerned about, particularly in patients with bipolar depression? So this particular meta-analysis looked at hypomanic or depressive in bipolar disorder, and they found that manic or hypomanic switches ranged from 17.3 to 48.8% was more common with antidepressant monotherapy compared to combination of treatment with other drugs. So what we know is what has been shown in this particular meta-analysis too. If you're using antidepressant alone, the risk of switch is that much higher, but the risk of switch is very low if it is used in combination with a mood stabilizing drug. And how long to continue antidepressants? Again, this is a study that we had done here at NIMHANS and a few other centers and published recently in New England Journal of Medicine, where we continued after the acute phase of treatment with escitalopram or bupropion along with the mood stabilizer. We continued them into 4 arms for 52 weeks, escitalopram versus escitalopram plus placebo, and then you're looking at mood stabilizer plus escitalopram, mood stabilizer plus placebo, and likewise with bupropion. We found that continuing it for 52 weeks did not have any significantly greater benefit than stopping the antidepressant at the end of 8 weeks. So, but there was no greater risk of switch. So while we don't know how long to continue antidepressants, I think whatever we are doing in terms of stopping antidepressants after 8 to 12 weeks does not seem to have any say adverse outcome than continuing antidepressants for a longer period of time. The rationale for this was that we know that a depressive episode tends to last for about 8 to 12 months. So by discontinuing antidepressants earlier, are we exposing patients to a greater risk of relapse? So I think that was the question which we tried to answer. Last few slides. Advances and future directions. So what are novel treatments? What is the role in bipolar depression? I hope I have time, or am I overshooting time?
You're tired, no issue.
Doing good?
Yeah.
All right, wonderful. Thank you so much. So what is novel in terms of novel treatments? So these are the conventional treatments usually target the dopaminergic and the serotonergic system. Whereas the novel targets, we're looking at drugs that target NMDA receptors, norepinephrine, and serotonin transporters. We're also looking at glutamine modulation. We're also looking at some possible anti-inflammatory treatments that inflammatory agents that could treat bipolar depression. So some of the common drugs that come under this category would include ketamine, riluzole, pramipexole, brexpiprazole, and trimetazidine. I'm probably just going to run through this. So these are drugs that are probably not going to be used in every center, probably used only in more of the academic centers. Ketamine is something that a lot of emphasis is being laid on, particularly where use of ECT may be more difficult, and ketamine is something that can be used. But again, you would require a specialist to be available, and anesthetist who can monitor the ketamine infusion. So So that is always a challenge. And of course, we have a whole lot of other treatments that are being tried. I'm just going to briefly touch upon ketamine. There are about, I think, three RCTs and about 4 or 5 open label trials which have looked at ketamine for acute bipolar depression. And most of them have used zero point 0.5 milligram per kg infusion, uh, usually run on alternate days for about 6 to 10 sessions. One of the things that all studies report is that after the first 1 or 2 infusions, the response is quite tremendous. But at the end of 10 days or 2 weeks, the response kind of tends to taper off. So while it is very good in the initial couple of sessions, the response tends to taper off over time. In a study that we had done at NIMHANS, where we compared ketamine with ECT, with the bilateral ECT, while the response with ketamine was faster, at the end of the course of treatment, ketamine was not superior to ECT, or it was comparable to ECT. In fact, ECT fared better as a number of sessions increased. So while ketamine is a good option, particularly for rapid improvement in suicidal ideation, it may not be able to provide the sustained response that clinicians expect when it comes to treating acute bipolar depression. Another drug that is being tested now, so we recently published uh, a paper which reviewed the role of trimetazidine, which is a drug that has been approved to treat angina, and what are the molecular mechanisms on which it can be found to be effective, which it treat bipolar depression. So here we're looking at mitochondrial activity. We're looking at energy production and mitochondria. We say that, okay, decreased energy production in mitochondria probably underlies bipolar depression, and the reverse is true for acute mania. So trimethylcetine is something that could modify the energy production in the mitochondria and thereby bring about the necessary change and improvement in bipolar depression. So here we're looking at multiple targets and not single proteins, which are usually tested in drugs when you're looking at treatments. So the trial is about to start. We've got the funding, and we hope that in about 2 or 3 years we will have some information on whether trimethylcetine could be helpful in treating acute bipolar depression. Non-invasive brain stimulation. I'm going to talk more about ECT here. One of the earliest studies looked at ECT in unipolar and bipolar depression. As you can find in the particular table here, that the number of ECTs were quite similar. There was no major difference between unipolar depression and bipolar depression in terms of the number of ECTs required or the duration of inpatient stay after starting ECT or the ECT threshold. So ECT, it appears, does not discriminate between unipolar and bipolar depression. It appears to be equally efficacious. Of course, one of the things that we have to remember is that while ECT guidelines will always recommend ECT as first-line treatment for depression, including bipolar depression, the bipolar guidelines invariably speak of ECT as a second-line treatment, but our clinical practice does show that a lot of our psychiatrists use ECT, particularly in patients with severe depression, with prominent suicidal ideas or depressive stupor. You could say that almost 88% of our old psychiatrists have said that mostly or always they would turn to ECT as a first choice treatment if a patient is having severe depression and also has prominent suicidal ideas. So the role of ECT is something that a lot of us have. But again, it brings us back to the question whether everybody can have access to ECT, whether it can be provided in all centers. If it can, yes, this appears to be one of the most effective treatments for acute bipolar depression, particularly in patients with severe acute bipolar disorder. So we also have published some papers on clinical efficacy of RTMS, acute bipolar depression, which we published in World Psychiatry in 2016. And we did find that active TMS performed better than sham TMS in terms of the response. And most of these, I mean, this was a combination of all the studies, but when you looked at specific subtypes, it is a high frequency TMS to the left dorsolateral prefrontal cortex that drove this difference between active and sham TMS. There is a low frequency stimulation, bilateral stimulation, and theta burst stimulation at that time did not show any significant difference between the active and sham TMS. In terms of TDCS, of course, we have some RCTs and some open label studies, again, which looks at acute bipolar depression. Response rates vary between 18 to 95%. The important thing here is the anode placement is at F3 and the cathode placement is at F8 or F4 in most of these studies. So yes, there is some preliminary preliminary evidence for the role of TDCS in acute bipolar depression. And of course, where available, high definition TDCS also has been shown to be effective in treating acute bipolar depression. Again, this is subject to availability of the equipment. If it is there, then yes, this is one good option which is available for treating depressive symptoms in patients with bipolar. So I'm going to come back to this case vignette now for the benefit of PG students who may be attending. So this case vignette, which I described earlier, so how are you going to manage them? So inpatient, what's going to be the location of treatment? Are you going to admit the patient? If yes, where? How long? So these are some of the questions that should come to your mind immediately. Am I going to admit this patient to a high intensity nursing care facility or an ICU? Yes, probably because the patient has suicidal ideation, may make suicidal attempts. How long am I going to keep them there? How am I going to monitor improvement? What are going to be the focus of my treatment? So, in this particular case vignette, I would say it's a syndrome of depression that requires treatment. The severe depression itself, suicidal ideation, psychotic symptoms, and decreased sleep. These would be my targets of treatment in the acute episode. So, how am I going to treat these symptoms? And like we just discussed, the presence of severe depression, suicidal ideation would automatically dictate to me that ECT should be one of my first choice drugs. In terms of pharmacotherapy, we've discussed the various drugs that are available to treat. And if you're looking at rapidity of response, so what are the drugs used and the other psychological interventions that may be necessary, particularly with respect to ensuring compliance to treatment and adherence to treatment. Again, I'm going to come back to the slide here. So in this particular patient too, the rapidity of response is going to determine the choice of treatment as well as the past good response to treatment and what is the prophylactic efficacy that will look. So, maintenance treatment of bipolar depression, again, a lot of drugs that treat bipolar depression can also prevent bipolar depression. The usual drugs are there, quetiapine, valproate, lithium, lamotrigine. So, as you can see from this particular slide, lithium, quetiapine, lamotrigine, and a combination of quetiapine plus a mood stabilizing drug seem to have the most efficacy in preventing depression in bipolar disorder. So while there are drugs that are available to treat, there are drugs that are available to prevent. So it is always prudent to choose a drug that will treat and prevent bipolar depression so that future episodes of bipolar depression can be controlled or prevented. To summarize, bipolar depression is a challenge for psychiatrists. Suicide rate is quite high in bipolar depression. The treatment options are limited. We have a handful of drugs. Lithium, second generation antipsychotics are the mainstay of acute and maintenance treatment. Novel treatments are being explored, depending on different biological mechanisms. The role of antidepressants in BD is unclear, though it is used more frequently than what guidelines would recommend. Bipolar depression poses a bigger clinical challenge because of the diagnostic dilemmas as well as the limited treatment options. Likewise, consensus definitions for treatment-resistant bipolar disorder are quite difficult to come through, and very few treatment options are actually available for treatment-resistant bipolar depression. And we must always use our guidelines to try and tailor the treatment to our individual patient. So with that, I'm going to stop. Thank you so much for the opportunity and for the attention.
Thank you, Dr. Murli. So audible?
Yes, sir.
Yeah. And great presentation. You said regarding everything. I think covered all aspects of bipolar depression. Um, One question that at least I think in all PG rounds and somewhere what
Dr. Modi,
why
can I unshare the screen?
hello audible? Ah,
Yes, that's right.
yeah. So only question that I think single question asked like whether SSRI is to be used in bipolar depression, yes or no. Still unclear after a couple of decades that whether he's supposed to start SSRI or antidepressant in case of bipolar depression. What is the final answer? Because in your presentation you mentioned a lot of studies and ultimately what is the final answer? I don't know. I don't know. I read a lot of things, but I don't able to make out.
Sir, we can't get away from SSRI. That
Yeah.
is how, and we are going to use SSRI. The only thing that I would that I think tried to highlight is if we are using an SSRI, let us make sure that we're using it with a mood stabilizing drug at an adequate dose of the mood stabilizing drug. So when I say adequate dose of mood stabilizing drug, I would mean at least zero point 0.8 to 1 milliequivalents of lithium. If you're using valproate, let us use it at, 20 to 40 milligrams per kg body weight. If you're using quetiapine, let us use it at least 600 to 800 milligrams per day of quetiapine. If you're using a long-acting risperidone, then likewise the recommended dose. So I would say adequate dose of mood stabilizing agent would be the key there if we are using an SSRI. So SSRIs can be used, are often effective, though meta-analysis would say otherwise. But for me, the crucial factor is that it should not cause a manic switch. And so the therapeutic dose of the mood stabilizing drug is very, very crucial. And if you're using SSRI, we should also use it at a dose at which it has been shown to be effective in in depression. So otherwise, it's going to be inadequate dose of SSRI, inadequate dose of a mood stabilizing drug, no therapeutic efficacy, increased risk of switch. So I think that is what would finally come down to. If you're using, let us use it with adequate mood stabilizing agent.
While working with old age patient, that somewhere I used to say that treat the episode, follow the episode. I'm talking use of MS, motion agents. So, what do you think? What do you think this good choice means something bipolar depression or bipolar patient for a couple of maybe a decade, and persons getting the depression mania. What are the in patient with bipolar depression? Let treat SSRI and for and wait for next episode. Whether this is the right choice, as because a lot of it is in the older psychiatry. But what about the adult patients having bipolar depression for years and years? Do you think that's a good choice or not choice?
Which one, sir? Sorry, coming in. SSRI?
Treat the episode, yeah. Treat the episode with SSRI, and then after say 6 to 8 months, then let forget the episode, and then wait for the next episode.
I don't know, sir. I think I'm not able to clearly hear the question. So sorry, could you repeat the last part again?
Say sorry now.
Better, the better.
Yeah. Let's start. Let somebody get bipolar depression. We start with SSRI 20%. We treat that person for 6 to 8 months, and after that we stop medications and wait for the next episode. That is common dictum happen in only psychiatry. Means they are either exposing with most of the agent side effects. Let treat the episode and follow the episode. What's your take on for adult patients?
So you're saying that after treating the episode, we stop the treatment and wait for the next episode and then
Yeah,
restart the treatment?
yeah,
Uh, I don't know if you like my answer, but I would say no. Yeah, because now I think a lot of emphasis has started on, see, apart from preventing or treating mood episodes, we also know that each successive episode becomes more difficult to treat.
yeah.
We are aware of the cycle acceleration and other neuroprogression and clinical progression that happens if bipolar disorder remains untreated over a long period of time. We also know that cognitive decline can become quite prominent with each successive episode, particularly after remission from the episode in the euthymic phase. So, keeping all these risks in mind, there is more benefit for us to prevent future episodes. So, I think now we also have a lot of information to say what are or who are the patients who would benefit from long-term prophylaxis, including what is the severity of the mood episode, whether the presence of psychotic symptoms were there or not in the first episode. Again, an index of severity, whether the patient required hospitalization itself in the early episodes, in which case there is a definite indication for long-term prophylaxis. Whereas the other patients, I think, finally comes down to what the clinician decides. Like you said, a lot of people prefer to wait and watch, but if you're going by indicators, if you're going by clinical features, then I would say that any indicator of severity and with the potential negative effects that can happen with successive episodes, prophylaxis would be indicated from very early in the course.
Thank you. Over to my colleague, Dr. Gubbaha.
Yeah, Dr. Keswan, you have taken us through a wealth of data, I must say, and a lot of information. I have a question. You know, we've all been reading and going through these guidelines. They're updated every few years, and now we are getting guidelines from everywhere. I have a question. If you look at this last, I'm in psychiatry for about 2.5 decades, and I've seen that yes, guidelines keep changing. So the point is, are we managing the patients of bipolar illness today better as compared to, say, 2 decades back? I mean, is there any research which tells us that with these options, so many new medicines and better understanding, are we doing better in terms of managing bipolar disorder? Is one question I have. The other question I have is there are patients who are known bipolar illness for say 20 25 years. They'll come to you, and this is in context with the use of antidepressants. So the patients usually know that the hypomanic state is a very productive state of mind. They know it. And they'll come to you in depression and they'll say, you give me that medicine which jo mein thoda sa up kar de. If you give a mood stabilizer or an antipsychotic, they say, no, doctor, sahab, this is not the drug for taking us into that up state. You have to give the drug. And if you don't give it, you say so, you quote so many researches and your knowledge, they'll shift from one psychiatrist to another. So these two questions for you.
Thank you, sir. Very important questions, and kind of uh, takes me back to some of the things that I have also learned over the last 20, 25 years or so. Are we managing bipolar disorder better now than what we were doing earlier? I would say yes. The answer is yes. For long, we were taught that, unlike schizophrenia, bipolar disorder, or manic depressive psychosis, patients get better and then they have episodes, and in between episodes, they are completely all right and functioning well. So I think for a long time, uh, for psychiatrists, bipolar disorder was like Rahul Dravid, while schizophrenia was like Sachin Tendulkar. So, so right now, I think we are trying to understand that yes, they are as important. Bipolar can cause as much dysfunction. I think that understanding has improved, and along with that understanding has come the need to treat bipolar disorder more effectively. I think that would describe a lot of changes that have happened in the last 20 years or so. The last 15 years, I would say the concept of bipolar depression is something that has gained a lot of importance. So, like you were saying, earlier, the antidepressants were used more often than not. But the concept of bipolar depression and why treatment of bipolar depression should be a little different from major depression probably gained a lot of momentum in the last 20 years from 2005, 2006 onwards. And I think now we are seeing a lot of people, the very fact that we're having a seminar on bipolar depression shows us that the awareness of bipolar depression and how it could be pathophysiologically different from unipolar depression is something that we have understood. So I would say that yes, we are treating bipolar depression disorder better. We are treating bipolar depression better than what we were doing earlier, but the number of options that we have to treat are very, very limited, which is kind of tying up our hands. So we have to go to options that were available before 2003 or 2004, and which we were using as students or trainees to try and treat patients who don't respond to the medicines that have been approved for treating bipolar depression. So I think that's what, though we are treating better, we have to sometimes fall back on the time tested or old options when the current options no longer work. The second question that you asked is about the use of antidepressants. So I can completely agree with what you say. I have a couple of patients with bipolar 2 disorder who will say that their best or their euthanic phase is that hypomanic phase that they had for a week or 2 weeks. When they were doing all the kind of things that they have never done in their life. And they want they want the medication that would help. But unfortunately or fortunately, we can't induce hypomania. And hypomania is any day pathological. There's a fine line between hypomania and mania. And once the patient goes into mania, then it's the full-blown bipolar disorder. And manic episodes can cause far more cognitive damage than depressive episodes or hypomanic episodes. So I don't know how we're going to make the patient understand that hypomania is also not good for them. But I don't think clinicians will be able to induce hypomania, even if you prescribe an antidepressant. So I think the risk of harm is far, far greater than any benefit that that particular treatment can cause. So antidepressant, okay, using yes, but I'll repeat myself under the cover of an adequate dose of mood stabilizer.
Yes, sir. Sir, if I may come in, so there is a range of disagreements, suppose between myself and guidelines, and the maximum disagreement is with the bipolar depression guidelines. I see Kutipin, I scratch my head. Then I see this Lurasidon, I again am confused. So uh, the survey that you are quoting, 500 psychiatrists that quote 95, so I lie in the 95% of the persons, because in bipolar depression, what I have found, what I have seen my colleagues doing, and they are doing good, is use of mood stabilizer and use of antidepressants. Now, the way we had been taught when I was a fresh pass out, so antidepressant was a total no-no. It was a path that you are committing if you are giving uh, antidepressants in a bipolar person. But what will you do if the patient does not improve? So what gradually my evolution has been to use uh, the antidepressants, mostly SSRI, a plenty, as long as needed. And usually what I do is when the depression is over, so I try to taper it off within 2 3 months. So try to limit its dose, of course, under under mode stabilizer cover. So I think there is one thing, how the guidelines are made, how Qutipin got the first place. So many other things are there. So I think that we should be aware of. Now, an older molecule, trifluperazine. If Tufan Pati sir must have used it more than any of us. So TFP is a very good anti-anxiety, anxiolytic, antidepressant action is there. So why not that also? So but I understand that we are under using antidepressants, and the risk of manic switch is probably amplified. It is more of a bad press. It is because the amount of antidepressant that myself, you, my colleagues use, less number of manic switches as compared to the literature we have seen. So again, this is a personal bias, personal data. So that is one thing. So the risk of switch is overinflated, that I feel. The antidepressants are used less. We should be bold enough to use it. But again, under cover of a proper dose of mood stabilizer, minimum amount of time. Because a patient who is suffering and just we are giving Lurasidon, Qutipin, and patient is not responding, that is a we are not doing our duty as a doctor, helping the patient. So that is my what you can say summary of the thing. So your comments on this, sir? Are we
But
using
I
antidepressant
think
less?
we are saying the same thing, and I think I agree with what you're saying, and I think that is what I've said too. So when we say antidepressants, and I think we're looking at two or three different generation of psychiatrists. So for us, antidepressant means SSRI by default. Whereas when we were students, antidepressants included for us, first choice antidepressants were tricyclic antidepressants. So when we were taught earlier that don't use antidepressants in bipolar depression, I think they were referring to the tricyclics. And the propensity for tricyclics to switch is far, far greater than for SSRI. So cut to chase 20 years down the line, when we say antidepressant, by default, we think SSRI. By default,
SSRI,
we think
yes.
sertraline. By default, we will think of escitalopram or
Any
fluoxetine.
SSRI, yes.
So the risk is definitely much, much lower. The switch rates are much, much lower with these drugs. So yes, I do agree with you that under the cover of an adequate dose of mood stabilizer, using an SSRI where it would benefit the patient is definitely indicated. Avoid using tricyclics. I think that is a better way of putting it. And that
Yes.
is what I think will work best for the patient. Regarding the use of quetiapine or lurasidone or the other atypical antipsychotics. So like I was
Asinapine,
saying,
if you say.
SNFin, so what the reason why I would probably use those drugs ahead of a combination of mood stabilizer plus an antidepressant is because I don't know what the next mood episode is going to be. Like, while we may not have an increased rate of switch, a recurrence or a relapse is highly likely, especially in patients who are having multiple episodes. So if I were to choose a drug, see, I would want to choose a drug that will do all the four things: treat and prevent mania, treat and prevent depression. And we're looking at those drugs. And then you're looking at drugs like say, cariprazine or quetiapine and probably lithium. Even lorazepam will not fit the bill there. So the number of options that we have, which will work in both poles of bipolar disorder as well as prevent both poles, are limited. And I would want to choose that. Whereas if I were to choose a mood stabilizer plus an antidepressant, then the antidepressant, like you said, you are going to discontinue after some time and the prophylactic drug will continue. Now, the question will be that was that drug, the prophylactic that we're using, if it were effective in the first place, wouldn't it have prevented that depressive episode in the first? So I think that question is that. The question is after treating the current episode, what are you going to do in terms of preventing future episodes? And I think that is what would dictate whatever choice we do make. And like I said, I agree with you. Mood stabilizer plus SSRI. I think if we use the term SSRI, a lot of
Yeah, yeah,
confusion
that
can be
will
avoided.
sort out the things a lot. And so suppose if there is comorbidity of substance, personality traits are there, and cognitive dulling is starting. So in those different scenarios, when bipolar depression is accompanied by certain things, so what is your choice? What is the thing to do there?
So I think there your choice is as good as mine. We will not have any evidence or guidelines for naturalistic course of bipolar disorders, and that is always going to be a limitation of guidelines and clinical trials, where we are more likely to have pure samples of the illness or enriched samples of bipolar disorder rather than the naturalistic samples. Most of the things that you mentioned would be exclusion criteria in clinical trials, rule out people with substance dependence, personality disorder, or any other access one psychiatric disorder. So, but what we see in clinical practice is quite the opposite. So, our understanding is that you have to treat them concurrently and you have to treat them without worsening each other. Like, for example, if you would ask me which drug would work best for a young lady with, say, borderline personality and bipolar disorder, one of the drugs that I would think of first would be carbamazepine or oxcarbazepine, right? Which is not something that would figure in as a first choice for treatment of say, mania or prophylaxis of bipolar disorder. But if you go by the most of the network meta-analysis on mania, carbamazepine comes out as the most effective drug in treating mania or preventing mania. But again, we don't use it often because its side effect profile is not so favorable. But in a clinical situation like this, a young lady, borderline personality, bipolar disorder, where I may not be able to use valproate, which will not be indicated, I would still fall back on a drug like carbamazepine or a drug like lamotrigine, which would work better, irrespective of what the guidelines. So I think finally it comes down to what the targets of treatment are and maximizing benefit while minimizing harm or risk from adverse effects, and also ensuring because intolerability is going to be the main reason why people will discontinue medications. So I hope I've answered your question.
So can I just get in the conversation? So two things. One is the doses of quetiapine which have been described are too high for an Indian population. 300, 600 milligram. I think patient will tell that we are worse off than what we were when we came to your chamber. I think quetiapine, Indian population, a lot of somnolence, a lot of sedation is seen in our population. So quetiapine is something we're thinking of sub-high dose. Another point I have always noticed is that treating bipolar depression is much more tougher than treating a bipolar mania. So one of the unethical things we do is sometimes we allow for a switch. Maybe put in an antidepressant, put in a stimulant, because bipolar depression is there is a very, very high chance of suicide is very, very high in bipolar depression, sir. That's one thing, because they have come from a manic episode to a depressive episode. And the change in the mood is too high, sir. If you look at the spectrum of change, so so they always want to remain in the hypomania state. So one of the better things to do is add antidepressant, add a stimulant, let them have a hypomanic episode or let them switch a little, take away the antidepressant, give the mood stabilizer and continue, or maybe hike in the mood stabilizer and continue. So, and another thing, I think this question has also come the role of endoxifen when it comes to personality, when it comes to substance. I've done a trial on endoxifen. I've done little worse things with endoxifen. Took the worst cases, the most treatment resistant cases, and I have seen good result with endoxifen when it comes to comorbidity with substance, when there are personality issues in terms of impulsivity. I think it's a little expensive drug, but I think it's better than getting somebody admitted and making them spend a lot of money. So your take on all these things, sir?
Thank you, sir. Three questions, three perspectives, and I think I'll take it one by one. The first thing is about the dose of quetiapine. Yes, I agree with you. But what we need to do when we are interpreting guidelines is to see whether we have given the dose at which it is uh, shown to be effective before we discontinue the drug. Okay, so while we may start low titrate up. A lot of patients may respond at 150 milligrams or 200 milligrams of quetiapine. In that case, there is no need to increase further. But if a patient is not responding, then we have to make sure that we have reached the dose at which has been shown to be effective in trials before we discontinue that medication and go to the next medication. So, in that sense, I would say that a lot of our patients would respond at 150, 200, maybe 300. But when they're not responding, invariably, when I go up on the dose, I find that they respond better. So, the guidelines, the trials will guide us in terms of what is the dose beyond which there is no evidence and at which there is evidence. And if I'm going to discontinue, let me at least touch that dose before I discontinue. Irrespective of whether they respond or not, and more often than not when they respond. Daytime drowsiness is a serious problem with quetiapine. And one of the challenges that we face, and patients are doing very well, but daytime somnolence is so high that they don't want to continue it. Extended release preparations usually are a little less somnolent than the plain preparations. Extended release preparations are something that I would try and ask the patient to try so that while the benefit is there, they shouldn't discontinue the medication because of sedation. So I think that is the first point. The second question is extremely controversial, and I don't think I'm going to recommend that. No, no way I'm going to try and switch a patient into mania. Because for me, it is easier to manage mania. No, probably I'm not going to agree with you on that. I would rather try and treat the bipolar depression. Of course, your perspective is well taken. Endoxifen, yes, though I have had a chance to read some of the studies that have been published on endoxifen. And endoxifen, protein kinase C inhibitor, has been developed in the laboratory for managing acute mania. And most of the other use has been off-label indications. The including personality and comorbid substance use and cognitive impairment. So it has been tried in a whole lot of conditions. But unless and until they put out the papers and publish them, it is going to be very difficult for us to. But they will always remain off-label indications. They will not be the indications for which we are using the drug in a particular patient. And yes, I do agree that yes, using endoxifen can reduce the need for hospitalization. But yeah, but most of the indications, apart from acute mania, are all off-label indications.
Should we take questions from the audience? There are a lot of questions coming up in
Yeah.
the chat.
Yeah, one thing, one question from lithium, because lithium, we all the time say this is very important gold standard molecule. Dr. Harbhajan asked whether lithium, the patient getting dropouts, weight gain, acne. So what is stand on lithium? What do you think that lithium is supposed to be the best drug for bipolar depression?
Sir, if you ask me, lithium is the best drug for bipolar disorder.
Yeah.
No second thought
Yeah.
about it at all, irrespective of what the guidelines may say, lithium is the drug. And its efficacy in acute bipolar depression also is quite good. The important thing, like all of us know, is the therapeutic levels. And we have to make sure that the serum levels of lithium are at least zero 0.8 to 1 milliequivalents per liter, maybe slightly higher also for acute management. For preventing, while we say that the slightly lower serum doses may be okay, I think I would still want to maintain them at 0.7 to 0.8 milliequivalents per liter. So lithium is always the drug for treating bipolar disorder, both in acute treatment and prophylactic. Acute treatment, we would require some other medication for more rapidity of action because to reach steady state concentrations, it does take some amount of time. So, like we've already discussed, maybe an SSRI for an acute bipolar depression or an antipsychotic plus lithium for acute mania is something that would probably work well and help reduce the symptoms that much faster while we can continue the patient on lithium for prophylaxis. The side effects are there, but then the side effects are, I would say, in a very small percentage of patients. If they experience side effects, the clinician has no choice but to change over to a treatment which produces less, because that is one reason why people are going to be non-adherent. Intolerable side effects. And for a young girl, acne is going to be a very serious side effect, even though it may not be life-threatening side effect. And I think if the patient does not want to continue lithium because of acne, we have to go back to some other drug which will work as well. So I think finally it comes down to what drug works well and a combination of the tolerable side effects as well as maximum effect.
So if I want to respond, I think somewhere apart from lithium and valproate, want to pick up one drug, lithium is best. But somehow our new generation is talking about the current generation. They want to pick up valproate the first choice rather than keeping the lithium. So lithium they want to get the backtrack because maybe they not seen they tried lithium well. That's my say because somewhere our new psychiatrists they are not fond of lithium. So maybe that's the reason because this is problem experience I believe. So as they grow older, I believe they supposed to know the benefits of lithium.
Sir,
Uh, yeah,
I have my own take on that.
yeah.
So
Uh,
just to add here on this
Mm,
platform in last 3 months, we have
mm,
had 3 sessions on lithium,
mm.
and we promoted lithium, and a lot of youngsters also learned about it. Professor Mohan Isaac from Australia and Dr. Amandeep from AIMS Delhi spoke on lithium. So I think lithium is like taking a comeback as per the talks we did, sir. So Dr. Om Prakash, a lot of youngsters were listening to those talks. Just to want to tell you that.
Thank you for all those talks on lithium because I think we need to bring lithium back into circulation.
Liquid bag.
One of the reasons why I think, sir, people prefer valproate, and I would give the benefit of doubt to our colleagues in this profession, is that lithium monitoring is not possible in every center, and it is easier to do in medical college-based institutions or centers where you have a biochemical laboratory. But for a practitioner working alone, getting a serum lithium level routinely and getting the patient to comply with all those are quite tedious. One. Two, I think the local climatic conditions and how easily somebody is going to dehydrate and go into lithium toxicity is always going to be a worry for the clinician. And so I think these are probably one or two reasons why there is a great reluctance to prescribe lithium. Apart from that, patients who take lithium have always reported some amount of cognitive slowing, which is linked to a decrease in the processing speed that is seen on cognitive tests with lithium. Though lithium is far more neuroprotective and has better effects on cognition, the subjective experience of slowness of thinking makes it very difficult for patients to continue with lithium, especially if they've come down from a manic episode where the thoughts were very rapid and they were thinking very rapidly. So it is seen as relatively significant slowing of their thought process. So patients don't want to continue lithium. So these are probably two or three reasons. Apart from the fact that lithium molecule is very cheap, so no industry would want to promote lithium. So,
Another question I saw in chat box about ketamine. Oral ketamine versus IV ketamine in open IP. So what a role in bipolar depression for that?
sir, I think now
You
a lot.
mentioned our slides here.
Yeah. A lot of sublingual ketamine is being tried now, not only in bipolar depression, but in most of the other conditions also. The response is pretty much the same. The initial response is quite good, but over a period of time, the response does not sustain. So I think we will have to see. Again, it's something that can be used in places where access to ECT or monitoring of intravenous infusion may not be possible. Yeah, but in terms of evidence, it's very, very limited.
So there is an interesting question. In rapid cycling, we give one antipsychotic plus 2 mood stabilizers. Is there any role for adding a third mood stabilizer?
I think you can keep adding as many mood stabilizers as you want till the rapid cycling comes down. But I think it has to be done in a manner that, we're going to augment one mood stabilizer with another. And if the patient is responding to, say, the third mood stabilizer, the confusion for the clinician will be that are the first two mood stabilizers working, or is it only the third mood stabilizer that is bringing about the beneficial effect? So I think that is the question that is going to plague us. And then the clinician will have to decide whether to keep only the third mood stabilizer and take off the first two, or keep all three, with the risk of the probably cumulative side effects.
And so, how much time should one take before adding another mood stabilizer? 1 month, 2 months?
So usually 8 weeks is what
8
most
weeks.
of the studies would recommend. But I think a lot of times you expect to see the improvement within the first 4 weeks of starting treatment. I think the clinician can know in the first 4 weeks if the drug is going to work or not before they choose the next drugs.
So another question from Nepal, Professor Dr. Nirmal Lamchande. He asked about when to stop the treatment in bipolar disorder. I think we answered that part, the tapering and the dosage. Um, Weight gain issues again. One question I asked by one of the young psychiatrist. He asked about whether I should start RTMS or not in my clinical practice. This for you because when it's supposed to start RTMS in a routine practice as a private psychiatrist.
Sir, sir, RTMS, yes. See, if you're looking at bipolar disorder in general, RTMS is usually tried in patients with treatment-resistant bipolar disorder. Whether you want to try it in patients with bipolar depression as a as you know an adjunctive treatment to standard treatment, yes. I don't know if it is going to enhance efficacy, but a lot of times, most of the studies that I've cited have all been in patients with treatment-resistant bipolar depression, where it was added on as an adjunctive therapy to the standard treatments and has been found to be effective. So
So
I think
when,
it comes down to what the clinician wants to do there. A lot of times it can be used in patients who are, say, probably uh, prescribed ECT, but they don't want to take it, or the patient has an indication for a brain stimulation treatment, but has a medical condition that would prevent us from giving ECT. Yes, in those cases, yes, I think you could look at using RTMS. One of the challenges with RTMS for bipolar depression is that the number of sessions are about 20 and they usually spread out over a period of 4 weeks. And getting people to comply with that many sessions is usually a practical problem. So one of the things that is being done now is to look at theta burst stimulation protocols, intermittent theta burst stimulation, where the treatment lasts for a few minutes only. And we're looking at accelerated protocols. So the patient gets 3 or 4 sessions per day for a period of 5 days. So try and complete the 20 sessions within a period of 4 or 5 days. So I think that's the best way to ensure that the patient is compliant on treatment and completes the course of RTMS. Because if they're not doing at least 20 sessions, then it's very difficult for us to look at any clinical benefit that the patient may derive from.
Sir, suppose there is a patient of bipolar depression now. How to psychoeducate? What are the must be told points to the patient? What we should tell the patient? How should they care about themselves? Signs of relapse and whatever.
Thank you, sir. It's a very, very good question. And that is something that I think has to be done from day one of patients coming to us for treatment of any disorder, bipolar in particular. And I think so there is some information that we need to convey. One is what is bipolar disorder? What are these various mood episodes? What are the treatment options available? What are the early warning signs of a manic episode or a depressive episode? What are relapse signatures? A lot of times, patients, family members will be able to identify that 1 or 2 days, if he doesn't sleep, then third day he starts behaving like this. So, what are relapse signatures? What is the treatment that we are prescribing? Why are we prescribing that? How long should they take it? And what is the follow-up that is recommended? So, these are 3 or 4 different components that we must talk about in terms of bipolar disorder. One of the things that is very challenging for us to do is to talk about duration of treatment. How long should I continue treatment? So I think in a lot of cases there we would try and set some targets. Okay, let's look at it for the next 2 years. Then we'll review it. Then we'll see what we need to do. One of the things that actually we need to tell the patient is that in the acute phase of treatment, we may be using a lot of medications which will not continue for long. So we may be using benzodiazepines, we may be using antidepressants, which we may be using SSRIs, which we will probably discontinue after a period of time. And we're looking at 1 or possibly 2 medications for prophylaxis, which we will continue in the long run. So I think that information needs to go. We also try to minimize the number of pills that the patient has to swallow. So if possible, we try and use an extended release or a sustained release preparation so we can bring down the number of pills that they have to swallow. So if we can look at some of these things, plus also address any myths or misconceptions that the patient. And I'm saying something that has to be done over a period of time, not something that can be done in 1 or 2 sessions. So probably 4 or 5 sessions, which covers important aspects of bipolar disorder, preferably supported by a pamphlet which contains this information, is probably going to be the best way to ensure that they retain the information. We have developed the bipolar disorder information booklet for patients. It's available in 3 languages. I'll be happy to share the soft copy with the team so that it can be circulated. We have it in English, Kannada, and Hindi. Information booklet for
Sure, sir.
patients.
Sure, sir. We'll do that. We'll do. Sir, one last question from my side. We have olanzapine fluoxetine. Why not olanzapine escitalopram and olanzapine sertraline?
Sorry, sir, come again. The question is?
We have olanzapine fluoxetine combination. So suppose I want to remove fluoxetine and add sertraline or escitalopram there. So what is the problem?
No problem. It is just that olanzapine fluoxetine combination has been studied, whereas olanzapine, sertraline, or escitalopram have not been studied. And I think it goes back to the fact that this trial was done at a time when the other SSRIs were not yet in the market. And so the study that became instrumental is the one which looked at olanzapine versus placebo versus olanzapine fluoxetine, where both olanzapine and olanzapine fluoxetine separated significantly from placebo, but olanzapine fluoxetine combination had a greater beneficial effect than olanzapine alone. So I think that became the basis. Plus, we also know that there is some kind of synergistic action between olanzapine and fluoxetine, where they enhance the blood levels of each other. It is not probably seen with olanzapine and the other SSRIs. So these are probably the reasons why we have that. Okay, you're always welcome to try olanzapine plus escitalopram. There should not be any issue. But there
Sir,
again,
in enhance, yeah.
so the dose of olanzapine should be such that it also has mood stabilizing property. That's what I was going to say.
Okay, sir, in enhance, suppose we don't want to go to antidepressant, we want to use a single molecule. So what is an enhanced experience? Single molecule for bipolar depression.
Sir, I use quetiapine extensively and have been doing so for the last 10 years with very good benefits. Quetiapine, again, like I said, individually tailored 200, 300 milligrams per day has good prophylactic efficacy too. Go higher if required for patients who are not responding at 200 or 300. So once you reach that remission, then maintain them at the same dose. So quetiapine has been my go-to drug for treating bipolar depression. I also had a fair degree of success with lorazepam and cariprazine. Again, the reasons for choosing these particular molecules are also in terms of the prophylactic efficacy, like I mentioned earlier. So, one drug which will treat mania, depression, which is an alternative to patients who don't want to use lithium. So quetiapine has been that particular drug for acute treatment of bipolar depression. When it comes to prophylaxis, lithium will always be the option that we recommend. And if the patients don't want to take, then we do have quetiapine or cariprazine. I'm using a lot of cariprazine of late for acute treatment as well as for prophylaxis.
So what are the doses for lorazepam and
So
cariprazine?
lorazepam I'm using between 120 to 160 milligrams per day,
Oh,
right? So one of the challenges with lorazepam or with cariprazine is the akathisia that they experience at the early doses. So invariably in the early stages, we are using it under the cover of a benzodiazepine, probably because the patient has sleep disturbances and the acute depressive episode. So the akathisia more often than not is taken care of by the benzodiazepine. In any case, increasing the dose also tends to have some kind of beneficial effect in akathisia. So 120 to 160 milligram per day, good improvement in bipolar depression as well as in the cognitive symptoms that are seen. Cariprazine at 1.5 to 3 milligrams per day. We
so
tend to
and
go,
and
sir.
so do you maintain them on also 120 to 160 mg or
Yes,
you
yes,
maintain?
same dose.
Oh,
Usually maintain them on the dose at which they responded unless they start having some intolerable side effects. But then there are very few drugs which cause dose-related side effects, isn't it, sir? So if the side effects are going to be there, you're likely to see them at the lower doses itself than at the higher doses.
so have you done any trials there, sir, in NIMHANS for this head-to-head comparisons
No,
with?
no, we are now looking only at the trimethylserine molecule. We have
Okay.
not done any trials with, but I have been, when I was working with Lakshmi Atam in UBC, that time the cariprazine trial was going on. And I think that's one of the trials that we have, included in my review also. But it has been shown to be efficacious and acute bipolar.
That is good. Yes, sir.
Thank you.
Thank you.
Thank you, sir. I think we are out of time totally. So now over to chairpersons for the remarks, then we go to Tufan, sir.
Um, I think we should be very thankful to Dr. Keshwan for giving such a elaborate talk. My learning from today is number one, I've added to my vocabulary these newer antipsychotics, which I was very cautious in using till now. And number two, my belief in the fact that the guidelines are guidelines, and we should always read them very cautiously, carefully, and we should learn the art of understanding these guidelines by reading between the lines. And why, how, what drugs what were chosen, and how were they chosen? At times, the choices are very logical. They are based on factors other than clinical factors, other than benefits of the patient. Dr.
Thank you,
Om
sir.
Hello.
Prakash, sir.
Om, sir.
I think this is a great presentation and almost all aspects of bipolar depression covered. Dr. Murli, thank you very much. I think a lot of things are very clear before this topic, and this is the area I think still psychiatry is working. We almost exhausted ourselves in schizophrenia, but bipolar depression is the one area I believe the young researchers must, I think, invest energy in this area. But this is the area, man, because one of the questions also missed somewhere, what are the new pipe up? There must be some guide, drugs are in the pipeline. But this thing is something I believe that biologically, the two, three diagnoses are important. One is CO-70 features. I all the time believe this is the category with different biology as compared to all other depressions. Similarly, bipolar depression, the person with bipolar depression, they have different biology as compared to as compared to all other depressions or all other mania. So maybe after a decade, maybe we have better answers at least about what happens with bipolar depression. We are clubbing in bipolar, we are clubbing in mania. I believe maybe after a decade, there's something different from this subset what we are clubbing with as compared to neurobiology, as compared to all other studies are coming up the last one decade. Thank you, sir. Thank you to Professor and Aline, Amrita, Dr. Vishal. I think for inviting me and thank you. Thanks for all. Sir, over to you, sir.
Thank
Irfan,
you.
sir, over.
Thank you, Dr. Kesavan, for this great lucid talk, and it was enlightening. I have got some observations. I have 4 decades of practice. I started practice in the most biggest center in Odisha, maybe the only center in Odisha at that point of time that we have psychiatry services. And we have used low dose major tranquilizers of those days and TCS. And I think we did not have this around 20 to 30% of switch rates in many in treating depressive patients. Secondly, about the adverse effect of TCS cardiac side effects, I have also mentioned in one. Then we used to, if some patient did not respond well with oral drugs, we selected from ECTs. And when we had to give ECT in a controlled situation, we eventually did cardiac evaluation for all the patients. Cardiac examination, ECG, and if required, further investigation. And the rate of atrial fibrillation or dangerous symptoms we rarely get because maybe only 3 or 4 patients have been kept off ECT for the cardiac effects. And I do believe personally that this thing that TCA can lead to severe cardiac effect in therapeutic dose has to be reviewed. But anyway, my choice of mood stabilizer in VPAD is lithium. That's my concrete choice because lithium was introduced when I was very young. I got lithium filter for SCV Medical College to start lithium. And it was gifted by me to biochemistry department. So I have felt its need. I approve of that. Thank you very much. A lot of learning on Teachers' Day. And my caption tells each one is a teacher. Cheers for teachers. Over to Amit for the last.
Thank you so much,
Amrit, over.
sir. We covered the length, the breadth, the height, and everything that was there in bipolar depression. Thank you for a wonderful coverage. Let me also thank Dr. Kulbahar sir, Dr. Gopi sir. Om Prakash sir, we are seeing you for after a long, long time. I'm so happy seeing you in our platform. One or two things I just want to tell that, as Tufan sir told, if you look at bipolar depression, my drug of choice, will be lithium at any cost. If there is any contraindication, if there is any renal issues, if there is anything else, then I will consider something else. Because if you give me 10 chances, 10 times I'll choose lithium over any other drug. That's based on what I see in clinical practice. Mania, okay, I can think of a valproate, I can think of a carbamazepine, I can think of oxcarbazepine, but per se, that is the drug of choice. Rest all, we have discussed a lot of things. Thank you for covering such an important topic. I'm also thankful to Vishal and Dr. Ali and all our viewers. And we have a lot of viewers today. I told this is a very good topic for discussion. And it is only the pharmacological aspect which we have focused on. Maybe we will have another topic on the non-pharmacological management of bipolar depression. And that will also go a long way in helping us handle a lot of issues. So thank you. Thank you, everybody. It was wonderful. A lot of attendance, a lot of questions, a lot of discussions. And at the end of the day, we go away knowing a little more about bipolar depression. Understanding,
Thank you.
I think, has improved. Good night. Have a great weekend.
Thank you.
Thank
Thank
you.
you all. Thank you so
Thank
much.
you, Amrit. Murli sir, thank you.
Thank you, sir. Thank you.
OP sir. Thank you, sir. Thank you, everyone. Wonderful time.